the Division of Health Systems and Public Health in the Department of Global Health at Stellenbosch University. I also work at the Western Cape Department of Health, and I've worked closely with the two colleagues who are presenting today, Alison and Donald. I know them both well, and they're going to be talking on the research that they've been doing in Cape Town at the Western Cape Department of Health clinics. Two important aspects. One is about retention and care of patients on antiretroviral medication. And we know that this is a challenge. It remains a challenge in our setting. And what we also know that, trying to keep people on long-term care, not just for HIV, but for any form of treatment, is always a challenge. And, there are many strategies that have been tried out, many that have been tested, and we know that it's complex. There's no simple solution to retaining people in care. So this project really explores that complexity and uses this approach called positive deviance. They will explain it in a bit more detail, where you're really looking at the positive outliers, those who are doing well, learning from them, and looking at how these can be applied in the same context to facilities that are not doing as well. So, it's a very useful, interesting approach to to try and improve the way we address this kind of issue. So I think without saying much more, I'm going to introduce our first speaker, and her name is Dr. Alison Ober. She's from the US. She works for the RAND Corporation. She's a senior behavioral science researcher. It's a non-profit research and policy institute, I think, despite the name. And, she's worked in HIV and substance use disorder research for over 20 years. Profile is in the, the advertisement for this particular talk. I'm not going to read it all out. But, just to emphasize, she's got lots of experience, and, she will, share and provide the setting for this project. And then Dr. Donald Skinner will talk, also someone I've worked with closely, over many years. So the topic of her talk is combining positive deviance and implementation science to improve retention in HIV care in South Africa. So I think without much ado, over to you, Alison, to do your presentation, and please add anything about yourself that I haven't mentioned. Thank you.
Thanks, Hassan. Hi, everyone. I don't know that I have much to add, other than, again, I'm a senior behavioral science researcher at the RAND Corporation. We do research to inform policy within the United States. We're headquartered in the United States. We also have offices in different locations in Europe. And I've been with RAND for 20 years and doing research in various aspects of improving quality of care and access to care for people with substance use disorders and people living with HIV. And this project is a very exciting project. It's unique, as Hassan mentioned. So I'm going to explain some of the background of the project and then methodology and some of our preliminary findings, because it's an intervention development study where the goal was really to develop an intervention and then to pilot test it. So we have some findings from the qualitative part of the study where we sought to better understand what was happening in clinics that were succeeding at retaining people living with HIV at above average rates. So with that, I will share my slides.
Okay, great. We can see them.
You can see them. Terrific. Okay. Everything looks good?
All good.
All good. All right. So again, as Hassan mentioned, the title of the talk and of our project is Combining Positive Deviance and Implementation Science to Improve Retention and Care in South Africa. We call it a community engaged intervention development study, and we're going to explain more about what that means and how we've engaged the community in various ways. And that's more in Donald's part of the talk. It is a pilot randomized control trial funded by the U.S. National Institute of Mental Health. And so today, as I mentioned, I'm going to talk about the background of the study, provide an overview, talk about the discovery phase and how we developed the intervention, and then some of the lessons learned, how we're going to then implement this and pilot test it, and how we're going to evaluate it over the coming months. So this is information that you all are no doubt well aware of, but despite increases in initiation of ART, South Africa as a whole and the Western Cape did not achieve 90-90-90 goals by 2020, and the 2030 goals aim even higher. As of 2018 data, that we had 66% of people living with HIV in the Western Cape were on antiretroviral therapy, and 85% who were on ART were virally suppressed. And then in 2022, when we looked at the data again, the average retention rate 6 months after initiating ART in Western Cape Department of Health provincial facilities was 43%. We realized that there are a lot of factors that go into calculating the retention rates, and these do take into account transfers to other facilities and various other factors. So in our study, we're using a community-engaged positive deviance approach to uncover unique strategies for addressing retention in ART. And looking at barriers. And so for those of you not familiar with positive deviance, it's the study of how a minority of individuals or even organizations more frequently, as we use positive deviance, we're moving into looking at it at the organization level, succeed at achieving their goals despite having common barriers. And so the approach began in the field of childhood malnutrition in the 1970s, where researchers went into villages where most of the children were malnourished, but there were select few families that weren't, and they did very intensive observational work and qualitative work in the field to understand what these families who were in the minority might be doing differently. And it turned out they were doing something very differently. They were including different components of vegetables, some of the roots and some of the other parts that people were typically throwing away, including those in the food they were giving their children, and that actually had an impact on their nutritional status. So the approach as a whole is doing that work to understand the positive deviance, and then engaging people who are doing the positive deviant behaviors in teaching or training other people how to do those behaviors as well. And so this sort of since then has expanded into not just individual level, but also organization level. But when we started the study, a few years ago, until that point, positive deviance had never been tested in an experimental trial as a complete approach to improving retention in HIV care. And also viral load suppression among people living with HIV. And so the word deviance sort of throws people off. It sounds like it has a negative connotation. But in this context, the deviants in the study are facilities that have above average retention rates of people living with HIV in treatment 6 months after they initiate their antiretroviral therapy. And the study, again, this word comes up over and over, community engaged. Our study is community engaged, and we really have relied on stakeholders for input throughout the entire study, every step of the way, so that we are sure that what we're developing is in the context of the very busy and very complicated clinics in which this is taking place. So community engaged participatory research plus implementation science research are both critical to future acceptability and sustainability of practices. And so this is why, again, like we really are emphasizing this approach, because it's one thing to do a study and come into a clinic and, develop an intervention and then test it and then leave. And there's no guarantee that it's going to be sustained or accepted, or it's even the right fit, for the clinic. So in our study, we have a stakeholder advisory board that's met 3 times so far, formally, but also we're in touch informally, always sending materials, our intervention manual, our training slides, and receiving input. The intervention is based on service delivery strategies that were derived from real-world clinic observation and qualitative work to ensure it's feasible and acceptable. So the whole first phase of the study was aimed at our going into clinics and conducting interviews and focus groups, and I'll talk about that in a minute, and surveys to really understand what is happening in the clinics. And then implementation science research is guiding implementation of our intervention, which we are literally just moving into this week and next week. I'm actually leaving. I'm coming from the US to Cape Town tomorrow to be able to be part of the initiation of our pilot study in the clinic. So we use principles in implementation science, like engaging clinic leaders, making sure we have staff buy-in at all levels of the clinic, developing a shared vision for the study, and then also providing implementation facilitation through the study, which Donald and his team that are in Cape Town are providing throughout the implementation phase to ensure that we have success and sustainability, that it's not just another research study that comes in and uses clinic resources and then leaves. So this is our research team. We bring together a really unique team with expertise in HIV treatment, health services, implementation science, and research methods. As mentioned, Donald and I are the principal investigators, and then we have co-investigators with Hassan, Dr. Virginia Zweigenthal, Dr. Laura Bogart from here in the US at RAND, Dr. Zeno Peterson in Cape Town, and then we have junior researchers on our team, Laletu Basakwe from Stellenbosch, Wadeen Victoria from Stellenbosch, and then we have consultants and a quantitative analyst, and then of course our stakeholder team. So as I mentioned, the study has 3 phases. The first is to discover unique or uncommon strategies that may not have already been studied, to really understand if there's, beyond what we know already in terms of barriers to retaining people in care, what are some other things that have not been looked at, then to develop our intervention and then to implement and evaluate. So we completed phase 1, where we identified facilities with higher and lower retention rates based on data from the Western Cape Department of Health Data Center. And then we conducted intensive research to discover these possible retention strategies. Again, we don't know if they really are retention strategies. We just know these are things that we discovered that are characteristics or qualities of these clinics, and then we'll test to see if implementing that makes a difference in our pilot study. And then we compiled the strategies. We developed a new program. Apologies. Find my mute. Second, let me just take care of this. Okay, I'm back. I guess some of the hazards of remote work. So compiling strategies, developing a program, and then planning for implementation. And then in the final phase, we'll implement at 3 lower retention facilities, which I mentioned that we're doing now. And we'll evaluate feasibility, acceptability, and effectiveness. And then, the outcomes that we're looking at is whether a higher proportion of people living with HIV are retained in care at our intervention clinics compared with all of the other lower retention clinics within the Western Cape Department of Health provincial clinics, and then also with viral load, people with viral load, a higher proportion that have viral load suppression. And so, as we mentioned, the study is taking place within Western Cape Department of Health, now Department of Health and Wellness health facilities within Metro Health Services. And I think we mentioned all of this already. And so now I want to talk about some of the data, the work that we did to actually really understand this organizational context and what might be serving as unique or uncommon strategies for contributing to higher retention. So basically, data from 6 facilities helped us understand these factors. We did organizational context surveys with providers and staff. We had 157 across 6 clinics. This was a challenging time when we did these surveys. It was right at the start of COVID and throughout COVID. So our response rate was a little bit low. We don't emphasize in our findings the results of those surveys because of our low response rates, but we did do some very nice organizational context surveys. And then we did semi-structured interviews with facility leaders at each clinic's provider focus groups. We did provider focus groups with lay staff and then with professional staff. And we did patient focus groups. And then we also did what's called patient shadowing, where members of our research team met with a person living with HIV, at the start of their clinic visit, and basically, shadowed them not in the exam room, but, in every other part of the visit to observe what happens when someone arrives. Where do they go? How are they treated by security? What line did they stand on? What's the interaction with the rest of the, patients? And then really everything from start to finish of a visit. And then in phase 2, we did a rapid analysis of the data. And so that really consisted of all members of the research team reading all of our transcripts and all of our notes. It wasn't actually very rapid, but we read all of the transcripts and we all came up with potential themes that emerged from all of the work that we did. And then we met with multiple stakeholders to categorize the most common themes. And the most common themes that came up were that at the higher retention clinics, there was a theme of engaging, encouraging, and supporting staff. So staff at higher retention facilities seemed to have more cohesion and felt more supported in their work by leadership, creating a welcoming physical environment where during even our observational work, when we all visited the clinics multiple times, the higher retention clinics were brighter. They had brighter paint. They had outdoor areas where people could sit during their long waits. And then we also noticed at the higher retention clinics, there were some workflow processes that were expedited and augmented compared to those at lower retention clinics. They had some streamlined filing systems, when they pulled folders, how they set folders aside if people didn't show up for visits, very, very, detailed part of the workflow that we noticed were slightly different. And also, some of these had to do with consistent implementation of some recommended workflow processes that were already supposed to be implemented and being implemented more successfully at these clinics. And I don't know what happened to number 2 on this slide. So you see it says 1 through, but very importantly, and our most important finding had to do with compassionate care and patient-centered care. We noticed that all of the staff and patients at the higher retention clinics talked about there being 1 or 2 people that really connected, and sometimes more than 1 or 2 people really connected with patients, and that patients felt a kindness and a compassionate care and a patient-centered care. It's ironic that somehow it jumped off of this page. Apologies for that. I'll explain it more in detail. But this is, so I'm going to go into in detail because it was our most interesting finding and one that we didn't know how we were going to address. So really at the heart of the findings were compassionate care and staff and patient connection. And, here are some quotes that sort of illustrate some of the findings that came up that led us to, this theme. From one of the patients at a higher retention clinic, they said, "My house burned down early in March. They came to where I live to show support every day." In this department, this is one of the sisters, one of the nurses. She's the one who told everyone about my house that had burned down. They brought me clothes for my children and shoes, for my children, and also shoes. They supported me, and that's why I don't have any problems with them. That's why the patient goes back there. Another patient said, "Oh, it's the way that the medical care," when this is sort of in response to what keeps you coming back to this clinic. That was a question that we asked. "Oh, it's the way that medical care staff caters to us whenever they came out. The way they make me feel, it makes me feel even more like you're an important member of the community and that you have an important role to play in the community, but you want to live and you want to feel important." And then a last quote just to share the fact that you can talk to the sisters. You can ask if there's something you're not happy with, and they will gladly assist you. So I think even that availability of staff actually makes it more, you feel more at ease, you feel that you will be helped because they would assist you. And of note, we also heard things like, I come back here because the sisters don't shout at you. So, we heard that, because out of frustration and a true caring nature, the staff sometimes get frustrated if people miss appointments when they fall out of care and they come back, because of course you care, and that's sort of a response, but it doesn't go over well with the patients to be shouted at. So many times we heard that we like it here because they don't shout at you when you come back. I think if you treat people as people, I mean, people will always come back. People will always come back because they know they can relate and there's somebody that actually cares. And so this information went into developing our new program, which we called Connect, centered around improving the staff and improving the patient experience. And these were our domains: engaging and supporting staff, creating a welcoming physical environment, expediting and augmenting workflow processes. And so our hypothesis is that a positive staff experience and a positive patient experience could lead to higher ART retention rates in these lower retention clinics. And in phase 3, we're testing our hypotheses. And so I'm just going to go in, mindful of time, I'm going to briefly review the strategies within each of these domains that we're going to be testing in this multi-component intervention. And then I will turn it over to Donald. So in the domain of encouraging and supporting staff, we developed this, what we're calling a monthly Connect huddle. And so the facility holds a monthly huddle toward team cohesion, support, and a shared vision for our retention. And it has some core activities such as Connect rounds. Connect rounds are based on Schwartz rounds, which is a forum for facility staff at all levels to share stories about the emotional impact of their work. You can look up Schwartz round if you're interested. It's actually fascinating. They've done some studies that showing that people who present in rounds, even higher level staff that, that show their own vulnerability when they're presenting actually raises feelings of compassion in other staff and also cohesion. So the idea is to sort of have a rounding, but a very carefully prepared rounding where the presenter is coached on the kinds of things to share, and also like supported in showing a little bit of vulnerability when presenting, and even talking about mistakes that were made or dealing with a challenging situation. And they're adapted from concepts in the literature suggesting that they may actually improve staff well-being. And I wanted to say too, like one of the most important components our stakeholders raised was that, engaging staff in a clinic in a research study is not the highest priority, but they also felt like it needed to be real and it needed to be for staff and something that would really benefit staff. And so we really took that to heart in developing it. It is for patients, and it's to retain people living with HIV and care, but really like to do that through improving staff well-being and cohesion. And then we also developed a compassion training to answer this question: can we teach compassion? Well, it turns out that there are some studies that have shown that compassion training with healthcare workers improves healthcare worker well-being. And so we connected with a researcher in Australia who has done some of these studies, who's an expert in what's called common humanity, which is the core component of a compassion training, which is basically recognizing common humanity in patients and in each other, which cultivates compassion. So it's based on these evidence-based compassion trainings. And compassion is defined as having empathy plus the motivation to help somebody, even if there's not really the means to help, or it's a small gesture, putting a hand on a shoulder, like we heard in those quotes, asking how the family is doing. Even these small things, it not only helps the patient, but it also protects the worker from what's called empathic distress. And so the research shows that feelings of compassion can be cultivated and can help protect healthcare workers. These are some examples from our compassion training slide, which we're actually implementing our first compassion training next Friday. So we're very excited. So this is just one slide where it's found, that one of the core components of the training is to teach the difference between empathy and compassion. And then again, the common humanity component is a key component of kind of shifting from a state of feeling tense and irritable with a patient who maybe you're feeling removed from, to shifting that mindset into seeing common humanity. So it's basically seeing this person as just like me. So this is part of our training where we teach common humanity. And of note, the trainer in this training, we do have a video from Dr. Debbie Ling, who's in Australia, but she's not giving the training. We have a trainer who's conducted trainings within the Western Cape Department of Health clinics for many decades. So he's very well aware of the challenges of working in the health clinic. So it's really made to fit very nicely into these clinics. And then in the second domain, creating a welcoming physical environment, the strategy is to make some physical improvements to the facility to the extent possible. So this is done in collaboration with the whole clinic implementation team. It's not the researchers deciding what happens. It's the clinic staff and community groups, and they decide this at some of their monthly meetings. They of course have to follow department policy and guidelines regarding which physical changes to make. And we realize also that budget is a big issue. And for this study, we're going to provide a small little stipend to be able to fund small projects, because we realize that it probably can't happen without that. And then again, expediting and augmenting workflow processes. So, we have some suggested ways to do this, like such as pulling files the night before, at least the night before, and setting them aside for people with appointments the next day, remaining at keeping the files at reception until the end of the week, so patients who had appointments in the earlier days get a chance to come back to collect their medications. And then at the start of the following week, the contacts and other key details from the files for people who didn't come in, who may be falling out of care, get passed on to the person responsible for tracking patients, and then the files are returned to reception. So this is like a very, very detailed workflow that the clinics themselves are going to have to adapt to whatever works for the clinics. We can't impose this, and some are already doing something like it, but pieces of it are sometimes falling through the cracks. As we know, it's complicated. This one thing alone maybe won't be enough to improve retention, but combined with what they're already doing and also improving implementation of what we think already, is supposed to be done may really help. And then, implementing welcome back service procedures. So welcome back service is the approach to take with patients when they return after an absence. And the guidelines are actually based on existing guidance from the department. But they're not implemented consistently. But we did find at the higher retention clinics, they are implemented. So really it's figuring out, how do we work with the clinic to implement these so the patients returning are not going to get reprimanded and scolded, but really they are reintegrated into care in a way that helps them feel welcome and stay in care. Showing genuine concern, avoiding scolding or blaming, checking on health and symptoms, exploring some of the barriers, and then facilitating ongoing treatment. And then, as I mentioned, several of the strategies are consistent with components of existing policies that are not consistently implemented. As we came up with these strategies, we learned, that we're not the first to discover that these are good ideas. So these, have been strategies, but they're not implemented. So and I've listed some of the strategies that we know about that already emphasize pieces of this. Obviously, patient-centered care is a goal. Having, an ideal clinic, a welcome reception area, differentiated models of care for people at different phases in their treatment, integrated service management, and the newer policy of, the MEC making every contact count, which Hassan can talk in greater detail about than I can. But in any case, it really fits in very nicely with the priorities of the department already. And, the differences between existing policies and our study is that our primary focus is on staff well-being and staff and patient interactions, and really the compassionate care. And then we also have our clinic engaged implementation and facilitation plan, where we're providing support to the clinic, and the implementation is really coming from within. And as we heard, we presented this to another audience, and someone said, oh, it's nice to see that we're bringing the people back, not just focused on data, which are really important to present and have people, kind of striving for retention goals, but also let's not forget that we have a lot of work to do also with bringing the people back and focusing on the staff and focusing on the patients. And so that is it. I think the next part is where we'll talk about the implementation and some of the lessons learned about, from the participatory research we've been doing. And so with that, I'm going to turn it over to Donald, and then I think we'll probably take questions at the end.
Yeah. Thanks so much, Alison. It was a very rich presentation. There's so much in that. Please post questions in the chat or just keep your questions for later. So Dr. Donald Skinner, also a long-term researcher. He's been around a while. He's a psychologist by background, worked for Stellenbosch before, then worked for the Human Sciences Research Council for a while as well, and he's now back appointed as a researcher at Stellenbosch. He's also, been active in teaching qualitative research at the university also for many years, and he's of course one of the lead investigators on this particular project, but overseeing the implementation. So Donald, you're going to talk about the next phase and additional lessons for health services. So over to you.
Okay, thank you. Let me just put this up. Thanks, Hassan and Alison, for their first part. What I'm going to talk about is really kind of the next phase of the program and looking at additional lessons and doing participatory research and the process of doing participatory research within Western Cape Department of Health or Health and Welfare. Sorry, just moving mine around a little bit. Okay. So as Alison said, this was our intervention to engage, encourage and support staff, which included the compassion training, creating the welcome physical environment, and to expedite and augment care, workflow processes, sorry. With the outcome of overall improved ART retention. So what we did from that step when we produced those results, being a participatory approach, we took that back then to make sure that we'd interpreted correctly. And we did a series of consultations. So we first went back to the stakeholders and we got strong input from 8 representatives on that. And this included people from the provincial office, facility leadership, staff, and patients that were part of the group, or patient representative groups, rather. Then we spoke to, and that was really useful just in terms of looking and understanding resource distribution, etc., and specifically the relationship between the different levels of the department. We then, on all 6 facilities that where we did research in the first phase, we went back and gave them feedback, both telling them about the results of the study and giving them insights or feedback on their own services. And this included, those who attended the feedback included the facility leadership, ARV staff, and the lay staff or the community health workers. Very interestingly, and again, this helped us enormously to understand what is going on in the facilities and started to give some real insight into why some of the higher performing facilities were there. Some additional consultations also held with, spoke to NGO staff and additional representatives from outside the group. So we spoke to people from Inova and from some additional staff. We did a general invitation within the department and got comments, and we had through 2 feedback sessions. And we even got Renita to take a break from her PhD to comment. And all of this gave considerable additional depth and understanding. And I'll talk a little bit about that additional depth and understanding as we move through the rest of the presentation. The other addition that we were asked to look at and came through in a lot of the meetings was, particularly in consultation with the stakeholders, and Alison has spoken about it, there's a lot of overlap with existing programs. From the ideal clinic, differentiated models of care, and not just the department policy documents, but also MSF. And so where possible, our manual contains some direct references to these policies. And certainly the process of retaining the files and the welcome back parties, we must give credit to MSF for and we've directly used their material. And then this made us feel more confident on the right line. This is a large overlap with existing policies, such as the MEC policy. And there's a hope that this, particularly the compassion training, could act as a direct tool for the staff to use in the MEC policy. Talk about staff and compassion, support and compassion. Idea, when we presented this at the clinics, it was very heavily supported, and there's very strong encouragement, particularly from the lower performing clinics. Comments like, I hope that the head office is hearing this, are you telling our manager, etc. So this is something to bear in mind. The major concerns amongst the facilities focused on workload with low levels of staffing, increasing number of programs, and increasing patient load. And even now when we're going out and talking to clinics again, the austerity programs are being commented on. So you just need to be aware of that and the impact of that on staff sense of self and their own feelings of being supported. The other process to bear in mind was the impact of COVID was incredibly significant in the clinics. And some facilities are still recovering. Some actually look like they're still reeling from the impact. And, facilities that had existing supportive cultures, which were broken down over the facilities and they're now trying to rebuild. We can, for example, one facility, they had a system of making sure they would eat together and would share food. Now, obviously, that was broken during the COVID period, and it's been really hard for them to try and bring that back together and to start building the clinic again. Around some of the facilities, there's also, and this does impact on support and compassion that the staff can feel, there's a real sense of threat from crime in the immediate environment. Which does put additional stress, adds stress to staff and patients. Adds stress to staff. Few did report theft or threats walking to work, and patients coming in feel additionally stressed, and it makes the interaction more difficult within the clinical encounter. Use of theory from outside the system. Alison touched on this a little bit. The ideal within positive deviance is we work exclusively with what's there. But in this case, there were some gaps, and we were trying to look at ways to fill those. Find ways of providing rapid support for staff and rapid recognition of the emotional impact of care. And that's really what the Schwartz rounds are about. They're about providing support to staff around the emotional impact of caring for one another and caring for patients. The Schwartz rounds are incredibly long and would not fit into and require certification, so would not fit into the DI department format. So we've adapted it to the Connect rounds, and we will see how this works. This was also, what was really positive is that a lot of staff within the department spoke of the COVID check-ins done at clinics and at departmental level during lockdowns, etc. And so there was a sense that this had been done before. And interestingly, in visiting many of the clinics, they talk about doing some kind of daily check-in on a clinic level. So we're going to be looking and seeing how this fits in. For the compassion, again, as Alison said, and I won't repeat it in too much in detail, we went for the model developed by Professor Debbie Ling, which focuses on how to see and work with compassion. And once again, with both of these, we'll just have to assess and see how they work in the Cape Town setting. You know, with implementation research and with participation approaches, adaptation process is continuous, and we keep having to look at this. And this includes working with the training center in the department to implement compassion training, and we are working closely with them. How to make the facilities more attractive? Surprisingly, this, you know, when I initially thought about it, this felt like the easiest, but it got more complicated. The more we spoke about it, the more complicated it got. I think the first is, you know, just improving the overall visual of the clinic. There was some uncertainty around where decisions are taken, how to take decisions, what can be done at the level with just the permission of the clinic manager. And there's a strong inclination to refer up to the point where where the request disappears. There also is a history of bad experiences of people coming in repainting clinics, but doing it in the wrong color, and the clinics having to be repainted. There was also a question of how to involve clinic members and whether this is a good idea. And this included raising the role of clinic committees. Now, the role of clinic committees has changed over time, and there's a lot of variation and uncertainty around what the clinic committees stand for, although from visits to clinics over the last while, the new structure does seem to have taken hold. Another concern was the potential for vandalism and theft. You know, some of the ideas were having artworks or putting up TVs for educational material, and there was concern around theft and the processes around that. Yeah, so anything that is added has to be put in a way where it can be locked down. A regular concern raised was around the provision of food and water for people while they're waiting in the clinic. And while seemingly obvious, this was actually extremely difficult, because for the provision of food, there's a contracting process that has to be put in place, and the potential for conflict with local communities also raised concerns. So we ended up with opting for the current system which sees a whole lot of food providers setting up stalls just outside the clinic. But hopefully we'll work with the clinic committees or the clinic leadership to encourage them to provide healthier food than chips and Coca-Cola. Water for people while they're waiting, again, had complications because of the potential for TB and COVID transmission. And again, we're having to look more carefully at that. Posters, we have, and anybody in this meeting who knows where you can get good, encouraging posters cheaply, please let us know. We have phoned around, traveled around, asked, and nobody can give us any ideas. Then there were some additional findings that were not part of the research. We're not part of the intervention. Just to talk about them, and this is mainly just for people to think about and consider. Staff and patients spoke about the importance of peer support. Now, there are two kinds of support here to consider. One were groups facilitated by a staff member, and this is very much staff involvement. So the first would be staff involvement. So this would be groups facilitated by a staff member, maybe attached to one of the HIV clubs, adherence clubs, or reminders of appointments. In some of the facilities, the nurses text the patients to remind them of appointments. But this does require a considerable additional commitment from staff. And some staff were sharing their own phone numbers with patients, so patients in an emergency could call them. It did raise concerns about overextending staff, and it's something that needs to be looked at, and I think has to be at the staff member's discretion. But it's a construct worth looking at. The second part of that is looking at informal groups or connections that patients manage themselves. And these are often formed while queuing for ARVs. While they're in that queue is a safe area from stigma because everybody is the same. So it's at those points that many people can share and talk about some of their concerns and can share ideas. And this, a number of patients spoke about as being really useful. It also allows for cooperative arrangements around the collection of medication. So, if people work and it's hard to get off work to collect medication, somebody else can do it. There's also getting around the issues of stigma and being seen in the clinic. If you have to go less often, maybe, it reduces your chance of being stigmatized. There's a danger of lack of control and misinformation. Pharmacy queues is a universal complaint across all the facilities and worse in the bigger facilities. Generally, these are the longest queues. And there's fear of exposure. I think the big fear with ARV patients is that the HIV status will be exposed when collecting their medication or when they're being called up. Some potential solutions that arose were extending the use of clubs or lockers for those receiving repeat packages and are stable in treatment. Staff in ARV care could collect ARVs and dispense from the offices, and this was done by one or two of the clinics and did seem to provide a great deal of, did seem to reduce the issues considerably. Integration of care, so no double queuing, and then pre-packing of common sets of drugs for dispensing. But we haven't tested these ideas at all, or even there's been very limited discussion with the pharmacy. So it's an area for future work. Stigma remains a major problem for patients and what they seem to talk about most often. Self-disclosure remains very low and fear of being identified very high. A number of people spoke about disclosing, even limiting their disclosure in their household and family. It's positive that the green cards have been phased out because this was very identification. But this hasn't completely changed the process, and there is conflict over the use of separate systems for HIV patients. It means more effective care and them getting out early, but leads to the threat of being identified. And integrated care produces its own problems. In one clinic where we spoke about, where they had integrated HIV care into chronic care, a number of the chronic patients were complaining that they now been seen as HIV positive and could they please be separated. So stigma is an issue that does need to be addressed at some level still. This was a kind of chance finding. One of the clinics, and I know that the department Wi-Fi is really not the greatest, but at one of the clinics, the clinic manager made the Wi-Fi open. And so what had happened is mainly adolescents and youth would hang around the facility in the afternoon. And I tried it. It took a while to download things, but if you're short on data and not, you'd be prepared to hang around and get it. So it did give the treatment facility a lot of positive credibility. I'm not sure if it produced any treatment advantage, and again, is something that requires further investigation. I now want to talk a little bit about participatory research and within the health service. Much of the health research that happens in happens around clinical work, and particularly medical trials and RCTs, which present somewhat less of a basis or open space for participatory work. But in the health systems research, there's much to be gained from drawing on the participation of clinicians, health workers, policymakers, and support staff. What we've found we gained and what is there is just the knowledge of the health system. And the health system exists at multiple levels. There's a formal health system, but there's systems that operate at each clinic that change and operate slightly differently. There's issues of context that are important. and the nature of the patients in each clinic. And I've been very interested to see just how varied the patients are between the clinics. Even clinics that are very close to one another can have very different patient loads. And interventions, and particularly doing intervention research, I think it is really important to do participatory work, to work on a participatory basis, because you get a much better sense of what is possible from staff and what the resources are. And to get interventions integrated, ultimately it has to meet both staff approval and be resource possible. Implementation research, again, Alison spoke about this, but so I won't talk about it in detail, but we start with a detailed description of the intervention based on our discussions. And we've discussed this in detail, as I said above, with the training department, trainers, faculty staff. So there's a modified plan that is now adjusted to then we have to modify it for the specifics of each facility. And then monitor the implementation to see how each was implemented. And one way, just from our current work already, the process of retaining files and using the files that aren't taken to follow up on patients. Two of the clinics for phase 3 that we visited are already using the system, but are meeting with problems further down the line, particularly in terms of contacting staff. So we've already sat with one of the clinics and started to look at that. And that, for me, is very much part of the implementation research to start, when you introduce a system, you have to make sure that it works within the resources and the context of the clinic. Acceptability will also be assessed for the intervention as a whole. So it's not just, it has to be implementable, it also has to be acceptable for the program. And we'll be looking at focus groups and observations in practice. So the idea is for each of the interventions, members of the research team will be there, but we also work in establishing very strong relationships with intervention champions in each of the clinics. And so in order to get feedback from them around issues and problems as they may occur. Interviews will also be done with the primary implementers within the facility, with the trainer, to assess further implementation concerns, looking at potential improvements, areas that are felt to be problematic, and the general program of trying to look at acceptability. Participatory research within the department. The experience and study, as you saw earlier, the study included Virginia and Hassan, who most of you will know. And this is important as we're working within the systems, and they were immediately able to give us direction both around how to get the research through the process, but also how to work within the systems, and preferably using resources. And how to use the resources within the system rather than bringing in external. The resources, we have had to bring in some external resources as the two elements of theory, and we are bringing some capital or some money in towards the paying for the improvements to the clinic, visual improvements to the clinic. But it's, advantages for the department. I think this allows the department to influence in a significant way the research process, so it focuses on the actual needs of the system. This research could have gone a very mechanical route and have missed a lot of issues. It can also deal with policies and systems, including new policies and systems, and was very useful here, as Alison mentioned earlier, just to be able to integrate what we were finding within the existence policy. And that both gives our findings additional validity and makes them more implementable. You can then tailor the resources to the research for further incorporation into the department. So when we were looking at how developing the intervention, it was better to go and speak to the training department and see how they operate, so to make sure that it's done in a way that they can implement later, and likewise with the clinics. And it's easier to set a pace for the research with the needs of the department. The advantages for the research: get more accurate and effective feedback and insight. Virginia and her son will regularly send documents, please comment, please look at, please provide critique. And when we wanted further, we would send to the stakeholders. And because they're part of the study, they were able to give feedback. It's easier to move through the bureaucracy and barriers, included getting access into the clinics. We didn't seek favorable treatment, but we were able to use our knowledge of that to get through. There's better insight into policy, as I mentioned before, so that works both ways. Can understand the health system on the ground. So if there are any problems or issues, I can go back and give Hassan a call or Virginia a call and find out what's going on, or they can direct me to the right person. So when we were having problems with one of the clinics in Khayelitsha, I was sent to the relevant person in the sub-district who was able to assist me and walk me through the clinic and set up all the processes. And can make sure that the interventions are tailored to the overall functioning of services. Problems of participatory research within the department. The workload on department staff is already high. So setting up meetings and getting responses is still hard work. And stakeholders, it's a difficult process to get all the stakeholders together. And we know that at some point we were ghosted for extended periods by some, and I don't blame them, and people have been pushed into a lot of work. So sometimes even getting responses to emails or calls can take up to 10 or more calls or emails, and that's particularly getting hold of the clinic managers. They're often the most well-hidden people. We appreciate that everybody works hard and already overextended in many ways. And I think that's been part of the understanding we've had to develop. And what we've tried to do is try to make sure that our meetings are always done at times that are feasible. We keep our inputs really short. And where possible, we provide lunch or at least a muffin. Muffins, lunches, food are extremely important. And I think one must take that seriously. It is a South African tradition. And I think we might have overdone it a little bit, but it does show respect and appreciation. Maybe don't need to do it at every meeting, but a core process is important. The department has multiple agendas operating at once. So practices can be overturned by a new core commitment, or you sometimes, when you think you've got a free run to implement something else has been implemented by the department at the same time. Yeah, and that is a massive bureaucracy and conflicting systems can tie up resources and staff time. So as I said, we have selected these 3 returns. So just to where we are, we have selected and had acceptance from 3 low retention clinics. We have engaged already with the faculty leadership and champions in 2 of the clinics. The 3rd one, we're still battling to tie down a time. What has been really positive is the really excited response from the 2 clinics that we're working with. In the first, I'm not sure of the ethics of naming the clinics, so I would rather not. But in the first one, we met with them, and we're doing the first of the support group meetings this coming Wednesday and the compassion training next week, Friday. And we had a meeting with them on Wednesday where we sat with the team for about 45 minutes looking through the filing systems and those processes. So there's been a real commitment and an excitement from the clinic staff. In the second clinic, by chance, it happened to be the clinic manager have been working at a clinic where we were working in the first phase of the study, And so it's familiar with the work and familiar with us, and we've been able to set up processes very rapidly. So at the moment, things are going really well, and we're hoping that it continues with that. We'll evaluate several things, several outcomes. There's implementation, which you spoke about earlier, the feasibility and the acceptability of the strategies. And it's also looking at the extent to which each strategy was implemented, because that's going to be important. Some are going to be difficult. And then how do we sustain Connect as a system afterwards? Yeah, these monthly meetings in particular are very easy to fall away. If we put a small intervention in to improve the overall visual effect of the clinic, how do we keep that impression and that idea alive that it's important to do that? And if we're able to draw community members in, how do we maintain that link? And then effectiveness. On this, we're going to be looking at art retention and viral load suppression amongst people living with AIDS, and this will come from the data center, and we'll be looking at changes in compassion towards others. That's we won't have to measure qualitatively, so we'll be less precise. And thank you. I think I've used up more than my half hour, so I'm going to close for now and go back. Thanks, Hassan.
That's absolutely fine. Thanks, Donald, and thanks for that reflection on, you know, all the additional work, the complexity of the intervention, and also the challenges that you had, you know, working in a real life environment. We struggle with implementation. The often, you know, attempts to apply very simplistic solutions to some of the challenges. And I think what you've offered here is a lot of depth, richness, and a lot better insight into, you know, what those difficulties are. And it's very much a bottom-up approach. I mean, I think, yes, you referred to myself and Virginia assisting you, but I think the core of what you did was really reflecting what you saw in the clinics, what you heard from our staff, and I think that's really, you know, the best part of what you did. But of course, you engage with multiple, you know, stakeholders, you know, where appropriate. So yeah, so thanks very much for that. You know, the floor is open for questions if anyone wants to ask, but I'm going to start off, and, you know, I mean, your focus was on improving retention in care for HIV patients. But my question is, surely this is more broadly applicable. We struggle with TB patients, we struggle with diabetic patients, you know, remaining in care, you know, a whole range of you know, reasons why people don't come for follow-up visits. So my question to you is, surely, you know, this is more broadly applicable, what you've picked up, and, you know, some of the solutions that you've proposed. Would you like to, you know, comment on that?
Yeah, I'll take this, as if that's okay. I think you know, we already seen that. You know, when I went to the first clinic and they're saying, and we get pulled in, and you know, as I left, the head HIV doctor said, you know, the meeting you're coming to on Wednesday, they're mainly going to want to talk to you about TB outreach. So yes, the clinics are already seen it, but, you know, for the purpose of research, and unfortunately we are primarily researchers, we've got to stick to the objectives. Once the tools are there and we hand them over to you and Juanita and everybody else, you can do with them as you like and develop them and take them further. So, but definitely, certainly certainly as the process of becoming integrated, the clinics are seeing this as something that's universal and are pushing to try and get all their staff into the compassion training. And we had to almost insist that the support groups, Connect rounds, are only the HIV staff and not all 30 people in the clinic.
Yeah.
That's already there.
Yes. No, great. And I mean, that's good to see. And I mean, certainly, you know, we want to see a broader impact, you know, the the challenges that you've picked up don't just apply to HIV patients. It applies more broadly, and the lessons learned, should be applied more broadly as well. I'm checking to see if there are any other questions.
There's one in the chat, Hassan.
There's one in the chat, yeah.
Yes.
Yeah, so do you want to take that one, Alison?
I will read it, and I don't know if I can answer it properly, but maybe the three of us can. So this says, thank you for the really in-depth exploration of the experiences of patients and staff. I'm interested in the clinic aesthetics. I like how the recommendations were considered. My question is, how big of a factor does the clinic look and feel play in the bigger scheme of things with regard to retention? I mean, I can answer from a research perspective, which is that we don't know yet. And also, because we're not only studying improving clinic aesthetics alone without any of the other changes, we won't really be able to know if these factors on their own make a difference. But together, combined with the other components of our intervention, we'll know. So in our research study, we won't be able to answer the question of like, what is the size of the effect of changing the aesthetics? But we do think that together with the other components, we will be able to take a look at whether the package as a whole has an impact. So maybe in a different study down the line that studies aesthetics alone, we can answer that question.
Yeah. Thanks. There's a couple of people who I know here. There's Elsie Marie from ANOVA. I'm going to pick on you and ask you, you haven't commented in the chat, but you've also worked as ANOVA in HIV, in retention and care, and so on. Any sort of thoughts and reflections on what you've heard today? Sorry, I'm putting you a bit on the spot. And Helen, from a scaling grant perspective, I'm coming to you next. Elsie Marie.
I'm so unbelievably thankful this is one of those meetings where I did not duplicate meetings. so I could follow the question. Can you hear me?
Yes, we can hear you.
Yes, so I was actually reflecting with some of the work that we've been doing with City of Cape Town and their 100 facilities project, which is also part of this Operation Phuthuma, which obviously looks at retention for art. So I have been in a reflective mood today, and it's interesting how very closely this aligns to what we found has worked quite well in this project as well, including creating time for conversations, creating teamwork, not only being data-driven, but being more patient-centered and maybe staff-centered as well. And then it also very closely aligns to another study that we, in ANOVA, that we also try and implement, which looked at factors. I think they call it like a choice study, where they would give patients different choices to which what would be the biggest factor of whether they would attend a clinic. And the findings were so interesting, where people would travel 5 times further just to find a compassionate and kind, and they use the word kind, healthcare worker. So those 2 things have been so critical, but it's very challenging to implement on the ground. Obviously, ANOVA has been supporting through the Welcome Back campaign, but I'm very excited about this work because it seems to almost make compassion a bit more practical. So I'm very excited to get the outcomes of this study, because I think it can be something that we can support further than just the Welcome Back campaign, where we just tell the nursing staff, you mustn't shout, like, being a bit more practical onto what does this kindness entail and what does the staff wellness entail. But yes, then building on that, I think unfortunately how busy clinics are is an extremely important point, and we're not getting past that very quickly. So those are some of my thoughts for this, but amazing work, really.
Absolutely. And I mean, I think that's one thing that I also found really interesting is the whole question of, can you teach compassion? What does it actually mean? So Alison or Donald, do either of you want to sort of respond to Elsie? You're on mute, Donald.
Yeah, and I think the compassion I now had spoken to some of the other people in ANOVA, and ANOVA plays enormous services, and I know there's a huge overlap, and each of the clinics that we've been to talks very positively. So, and there does seem, but I think that we'll be looking and giving feedback, and I think the approach that we selected is something that is usable from a senior professional to a community health worker. There's no specific academic training required for it. So hopefully that will allow itself to be more generally shared. Whether it can work I'm hoping it will, but we'll have to just assess. I've been trying it in my own life, and I'm swearing less at other drivers, which might be a positive indicator. Alison, I don't know if you want to add anything.
Yeah, please do add, Alison.
Yeah, I mean, I agree everything, Elsie, with what you said. I mean, we considered all of these things, at the beginning, is how do we operationalize it? Like, it's one thing just to say, oh, be more compassionate, but, sometimes we can't, and life is busy and clinics are busy, and I think having some practical tools to be able to stop in the moment and, employ some of these key components is really important. And I think that we eventually, we're doing a pilot study, which is really critical. But I also think another component is to do a larger study of the compassion training alone to see if we can isolate some of the impact of, can a compassion training really change some of these behaviors? And the other thing I wanted to say too is because this part of it is a pilot implementation study, we'll learn from staff. We're going to be asking staff afterwards, how it went and if this made a difference and what else will they need, do they need to be able to implement this. And then I guess the last part of it is, and Donald mentioned this as well, is the sustainability. So we could do this training and then we'll check in a few months, but really how do we over time continue to change the culture of a clinic, to remind people to employ these strategies. Our study coffee mugs that we created, the coffee cups have a compassion slogan. So we think that's good, but it only can go so far. So we'll have to be really, talking with, thinking down the road, if this is implemented, how do we sustain it and how do we keep these messages and skills in place for people, despite all of the many challenges. And, I think that having somebody do the training who is, has been in the clinics and understands this component of having a very busy, clinic and real challenges on a moment-to-moment basis is critical as well, because otherwise we wouldn't be credible coming in and just telling people to act more compassionately in the face of all these tremendous barriers. So we'll be learning more about implementation and describing it, in our outcomes papers, which we'll share with you, what we can do to improve the training, and then I guess further test it in a future study.
Yeah, and I mean, you doing all the work that you're doing, you have sustainability in mind. You're working with the provincial development center, the PDC, with a provider who can deliver the training. So it's not something that disappears when you are not here, which I think is, just the way, it needs to be done. Helen, I'm going to pick on you. I mean, you're working in the Scaling Grant project, which again takes a slightly different approach to retention in care. Just ask, what are your reflections?
Thanks, Hassan, for picking on me. Just want to say thank you, Donald and Alison, for sharing this. I think it is really, really important, and also maybe looking at our work that we are doing. I think my reflection to this is, yes, people are very busy in the clinics, and how do we implement what you have done in the facilities that we are targeting at? Because we, for this coming phase, we are also looking at different facilities, and we also understand the compassionate training that you guys are doing. And it'd be great to hear about the outcomes, with the facilities we work with, they are always very busy, and, there's always staff burnout and staff being on sick leave. So there's always shortage of staff. So how do we keep staff compassionate when that happens? And then, with patients, we also see the stigma part that you have mentioned. Patients, as you said, rather go to another facility, traveling to another suburb or something, just to not be found out that they have TB or HIV. So that's also the things that we picked up in our in the phase that we worked in. So there's a lot of patient movement as well to that, and maybe how do we attract those patients to the specific facilities that they need to go to. It'll be great just to hear about that as well. So that's my 2 cents. Thanks, Hassan.
Right, thanks, Helen. I don't know if either of you want to comment. I think Helen just made really a comment and giving you feedback. Anything you want to add?
Just to thank Helen provided some really useful input as we went along. So also just to thank her for that. And
Right.
we'll be calling on her again soon, just to warn her.
And again, I think just to close off, I think the province, the country is in a bit of a crisis with respect to our financial situation. We are we are in a austerity environment. There are we have to cut back on services. So we're trying to move forward. There are these interventions that are being developed, but this has been the story of your particular project. COVID happened during your project. The other projects working in and policies changing, like MEC coming along, or other changes. So you're working in a dynamic environment where a lot is happening, and the current environment is quite severe. Budget austerity measures that are in place. So I'm going to ask you perhaps just to comment and perhaps make some closing comments about your project. But how does your project relate to the environment that we're currently going through?
Alison, do you want to go first, or should I?
You can go first, Donald.
Yeah, and it's a complex question, obviously. And I think the participatory approach is useful because it allows you to constantly adapt. And obviously the ideas and the responses we would have got prior to COVID would be very different to what happened after COVID. And having that kind of participatory, flexible approach does give a huge advantage. And I think particularly that flexibility, even when it comes to implementation, is extremely important. And and COVID itself, and I think it had enormous impact on the health system. And I think in some respects, there's a need to go back and relook at how clinicians and patients relate. I think it changed I think it changed approach to vaccines, approach to healthcare, approach to hygiene in many, many ways. And we need to really I don't think we still fully understand that, but these kinds of processes are starting to produce some answers, at least.
Alison?
I think it's a great question. I mean, as you mentioned right from the beginning, Hassan, it's a challenging environment, and we don't want to be naive and think we can do one intervention that will change retention everywhere. I think, and I think, again, like Donald said, that's where the participatory element's really important, is to make sure that we're not coming in a naive way saying, we have the answer for you. We worked throughout, challenging times. It's been a challenge this is the year 5 of a 3-year study, by the way. So
Yeah.
we've really had our own challenges. So, I think that, sort of ground up approach is really useful. And then I think the other thing to keep in mind is that, the positive deviance approach from its origins really it's not about coming in with very expensive solutions, because that's not a reality. We have like very limited research funds left to even provide stipends to make aesthetic improvements. We're not giving out a lot of money, to do the study. Our goal has always been to create something that fits into services in a resource constrained type of clinic, so that it's not so that it can be sustained, because we know that if we were paying for everything, or if we were paying staff, sure, like we are providing food here and there, dinners and snacks, and to increase participation, but trying to keep everything we do within a very kind of limited budget for this very reason. And I think back to those original positive deviance studies, in childhood malnutrition, and that that's it's supposed to be a very low resource intervention that can be implemented across clinics that face the same barriers. So everybody's facing, this resource constrained barrier. So we were very mindful in thinking about, how to develop strategies that really are not costly. I know, having a trainer, costs money, but it may fit within the existing budget to include the compassion training. So things like that. So I think in our assessment, the overall cost of conducting this study and learning about these barriers was large, but the cost of implementation and the strategies themselves, we don't think is very high. Isn't very high.
Thanks so much. And I think, yeah, I mean, absolutely. And I can testify to the fact that you were very mindful about, implementing sustainable approaches. You've prioritized what needed to be, which of your interventions, which, came up through the first or early phases of the project. You had to select which ones you want to prioritize, but in consultation with all relevant, stakeholders. So that's been enormously valuable. But again, I mean, you've given us all insight into the complexity of one particular issue, which is about retention in care of, patients who are on antiretroviral treatment. And just that one issue has generated a huge amount of information and, has given us insight into the fact that there are no simple solutions. There's no magic bullet that's going to, solve this issue, that there are multiple things we can do that are affordable, sustainable, but we're talking really about incremental change. You've given us insight into the challenge of implementation and what implementation means. And I mean, you've told us about how bureaucratic we are, what barriers, how slow we are to answer emails, and how, moving forward with any intervention, does take time. And I think it's useful for us to get that kind of reflection back, but it also gives us insight into, what it means, what implementation means, and why we struggle, with the implementation. So on that note, I'm just going to ask everyone to just give both of you a round of applause. I don't know if you can put your cameras or your unmute and, just give a round, or, or do a virtual hand clap if you like. But well done to all of you, and fantastic. That was a very interesting and, useful presentation. So I think from my side, we are recording this session. Thanks to all the participants who joined us this afternoon. I hope you found it extremely valuable. Thanks to Chanel for all the logistics and just making sure that everything works fine. But then lastly, again, just thanks to you, Donald and Alison, for informing us today, for educating us about this work, and we look forward to the further results. Thanks so much.
Thanks,
Bye, everyone.
Hassan, and thanks for your contribution as well.
Yeah, sure.
Okay.
Bye-bye, everyone.